And my task today is to talk about the elimination of HCV in people who inject drugs and prisons in Spain. These are my disclosures. So hepatitis C infection among people with recent injecting drug use is very high. There are at least 57 million living with HCV globally, and over 6 million people are recent injecting drugs. There is a 39% prevalence. China, US, Russia, and Brazil make up more than 50% of all HCV infections among recent people who inject drugs globally. So HCV testing and treatment among those people remains low. 47% of people who inject drugs had ever received HCV antibody testing. There are 49 countries with available data, raised from 1% to 93%. HCV treatment coverage was low, less than 25% in 14 countries, moderate between 25 to 75% in 8 countries, and high, more than 75% in Spain. So we now have the tools to modify this situation. We have prevention strategies, needle syringe programs, opioid agonist therapy. We have a simple diagnosis with available blood tests, point of care, and dried blood spot testing. And of course, we have effective treatment, 1 to 3 pills per day for 2-3 months. We have over 95% cure rates without side effects. So combined, these tools can be used to eliminate hepatitis C as a major public health threat. Which is the problem? You have seen this cascade many times during the conference. So there is an important cascade between those people living with HCV infection until those who can cure, who can get sustained virological response. So this is a big issue that is probably because different reasons. First, multiple visits to diagnosis. We should avoid this approach. Those patients do not come to the hospital, and if they come for only one visit. They don't come frequently. Some of them are afraid of venipuncture. They don't know the infection, the HCV infection. There is a stigma in many of these patients, and for those of them, this is not a priority. So we have to modify the system of the approach of this disease. We should go to a patient-centered circuit. Again, those patients do not come to the hospital, do not come to multiple visits. So we have to go where these patients are. That means the alcohol and drug situations. We need the general practitioners to be involved in the screening of those patients. We need to go to the prisons and many other sites, so we have to modify and to go where the patients are. Diagnosis simplification is a key issue. We need one-step diagnosis, the sample with HCV antibodies, must have a reflex test for HCV RNA. And those positive should go for treatment immediately. So we should do liver stiffness, but this is not a limitation. We have the FIB-4 or the APRI test, and this is enough to assess the liver state. This is the microelimination program in people who inject drugs in Barcelona, Spain. And there was an interesting survey. The question was, do you have hepatitis C? Among those who answered no, 25% of them were viremics. For those who answered with a no, 55% were viremics. And finally, those who answered yes, I have it, 78% were viremics. So again, we need a harm reduction center to improve the situation and get the patients for treatment. So this is the organization of the program in Barcelona. We have a harm reduction center, point of care diagnosis, where the patients are, on-site treatment, and finally, an assessment of the sustained virological response after 12 weeks of treatment. And finally, in those patients, we need to assess the reinfection because the rate of infection is high, it's 6.2 per 100 patients a year without methadone or buprenorphine, so any opioid treatment. Which are the take-home messages for this population? We should externalize HCV diagnosis and treatment. It is feasible in these most difficult people to treat. Suboptimal adherence does not impair achievement of sustained virological response. Even those who are not able to complete treatment, the majority of them achieve sustained virological response. So HCV therapy has benefits beyond sustained virological response. You all know that the rate of HCC is much lower in those patients who receive treatment. Reinfection and other intrinsic barriers make HCV microelimination in this setting very challenging. And finally, HCV microelimination programs in this population should always include harm reduction interventions. Why treating patients in the prisons? So first, there is a disproportionately high HCV prevalence among prisoner population versus the general population. Second, people who inject drugs, a key risk behavior for HCV infection, are often involved in criminal behavior and spend time in prisons. Third, risk behaviors in the prison context are more likely to be associated with HCV transmission. Prisons provide an opportunity to engage marginalized individuals into health care because they are into the prison. So we have access to them. Curing people of HCV in prison may positively impact HCV epidemiology in the prison and wider community. We know that every infected person with HCV can infect 7 relatives or 7 people in the surround. So we can impact not only the situation in the prison, but outside it. In many countries, HCV care in prisons is limited, but the situation in some prisons is starting to change. What barriers hinder the elimination of HCV? The same cascade. You have seen this picture many times during the conference. So the Spanish national plan included people in prisons as a priority population. Penitentiary institutions were key collaborators in implementing the plan, evaluating key indicators. And the focus for people in prison was on prevention and diagnosis, harm reduction prevention, screening and diagnosis programs. This is an example. To simplify the strategy, we should perform the reflex test for any antibody positive. We have electronic alerts to test and refer to the hospital. And we have rapid test or a quick or GeneXpert or dry blood spot. This is an example of the El Dueso prison, a prison in the north of Spain. And they did all this program connected to the tertiary hospital. They had a system of video conference and electronic alerts, and the patients into the prison were connected to the multidisciplinary team at the hospital. In Cantabria, north of Spain, there are 600,000 people and 431 inmates in the prison. The HCV prevalence was more than 10% to 22% in 2011. This is the impact of HCV management in prison. This is the Spanish example. This is the analysis of the systematic registry of the informatic database of health penitentiary coordination in Spain. The registries go from 2015 to June 2019. There were included 71 prisons in Spain. And you can observe here the results from 2015 to 2019. The HCV viremia decreased from 11% to 1.9%. And HCV treatment rates were from 24 to 100% in 2019. This is the example in Catalonia. And we went from 10.1 to 0.09% of DAA treatments in inmates in Catalan prisons. So again, I have already said you can improve the situation, not only in the prison, but in the community. You avoid infections in the relatives and friends of the infected person. So the summary of HCV elimination in these vulnerable populations is first, have a national plan to manage hepatitis C. Diagnosis for elimination needs a reflex test for every HCV suspicion with a point-of-care test, rapid test. Linkage to care, this is an important feature, and harm reduction programs. This is absolutely important. And finally, I'd like to invite all of you to a meeting we will have in Sitges. Sitges is a seaside Mediterranean population, 30 minutes from Barcelona. We will have an international meeting in October 3 and 4, and we will be delighted to invite all of you to attend this meeting. Thank you very much for your attention.